Okay, our fourth speaker, unfortunately, he couldn't make it, Dr. Omar Abu Hijli in Jordan. So we'll meet him on Skype, through Skype. So he will give us a presentation for about 30 minutes.
سامعينكم والدكتور بيقدر يحكي. تمام. يلا اوكي.
دكتور عمر شايفنا معنا؟
ايوه قاعد بيحكي.
دكتور عمر هو senior consultant endocrinologist في Jordan Center for Diabetes and Endocrinology Jordan Hospital and Medical Center وهو president of Jordan Osteoporosis. Are you ready دكتور عمر؟ طبعا السكايب شوية
اعطيني اشاره بس قولوا ابدا.
انا عندي اشاره.
اطلع شوف.
يلا خلي الدكتور يبلش. يلا هلا بسم الله الرحمن الرحيم. مسيكم بالخير. في الواقع يعني كل شوق وحنين ان اشارككم هذا المؤتمر اللي بتمنى له النجاح، وانا زي ما شايف الجهود اللي بذلت في سبيل انجاحه من جميع الناس في الواقع مشكوره وابدعوا، وبالذات برضه بدي اقدم الشكر لشركه نوفارتس اللي خلت المؤتمر يستمر ونتمكن من نشارككم في المحاضره اللي القيها اليوم. في الواقع اليوم التوك اللي بنحكيها طبعا المقدمه هاي بالعربي حكيناها لانه الواحد اللهجه العربيه بتغلب عليه في الاول، هلا عشان في سبيكرز من بلاد اجنبيه بدنا نكمل محاضرتنا بالانجليزي. Today I will going to speak about the diabetes in general and its complication as in the plenary title, but I will really focus on a missed complication of diabetes. We always forget to ask patients about it, and we leave them in neglected agony. So the complication which I'm going to speak about is really occurs in about 30 to 90% of those with diabetes in different population. It's a very complex, it has a very complex pathogenesis owing to its combination of microvascular, macrovascular, endocrine, and neuropathic disease. And also is established recently over the last 10-15 years as an independent marker for the development of coronary artery disease. And it's occurring on average about 3 to 5 years before the onset of coronary artery disease. It's very serious complication, and it's a marker for a serious disease in diabetic population. Is really this complication common worldwide? Yes, the statistics show that in the United States there's about 30 million men in the United States affected by this problem, and worldwide it's about 150 million. It's predicted also that in 2025 about 30 million of men will complain and suffer from this complication, which mainly affected diabetic people. So, if we now go back a little bit, basic things about diabetes, and we think about what is the most prevalent complication of diabetes, I think all of you know this list, but I think there is something missing. I hope that because really the communication now, since I'm not with you in direct face-to-face, so these questions cannot be done properly. But I'll give you a hint about this complication. This is a portrait by Pablo Picasso in 1970, and it says the lovers. And when say the lovers, I think everybody comes to his mind that this complication is really erectile dysfunction. Erectile dysfunction in diabetics constitute one of the most common complications, as we saw in the previous slides. So, if we want to define male erectile dysfunction, it's the consistent or recurrent inability to attain and or maintain a benign erection sufficient for satisfactory sexual performance, and this is adopted by the National Health Consistent Development Panel in Competence, and also in the the Journal of the Sexual Society and Sexual Medicine Journal. Okay, is it really prevalent? This is a very, very famous study in Massachusetts, male aging study, which showed that in men between 40 and 70 years of age, about half of them complain from different degrees of erectile dysfunction. 17 of them, they have mild, and 25% of men between this age group, about 25% of them complain from moderate degree, and about 10% they have complete or very severe ED. So it's a very common complication even in the general population. And this is the same study showed that in the different degrees of erectile dysfunction, it depends on the age. If you are 70 years old, the probability of having erectile dysfunction between severe and moderate is about 50%. And of course, the probability will goes down with younger age. But even at the age of 40, about 40% of population have erectile dysfunction in different degrees. So it's really a very, very common. And the same study showed that the age-adjusted risk of erectile dysfunction was higher for men with lower education, diabetes, heart disease, hypertension, and of course advanced age. So now diabetes is one of the common high risk factor for erectile dysfunction in general population. What's the cause of ED? It's a very mixed, as we said, it's very complex pathogenesis. It's psychogenic. Usually psychogenic impotence, we encounter it in younger age group. In the people who are less than 40, less than 35, most of these kind of patients, they have some psychological element in their impotence. While with the advancing age, with those of more than 50 years of age, about 80% of males have organic causes. And the organic causes are many and complex, between vasculogenic, metabolic, neurogenic, drug-induced, hormonal, and many, many other rare causes of erectile dysfunction. And this makes really how to assess the cause, the exact cause of erectile dysfunction is difficult. But usually, the major risk factor for ED, if you look at this table, it's many. I will not go through all of it, but I can tell about aging and the chronic disease. And as we saw from the Massachusetts study, that diabetes, hypertension, and vascular disease are one of the most common causes of and risk factor for erectile dysfunction. The other thing important, which is the medication, and also the antihypertensive, the antidepressant, the non-steroidal anti-inflammatory drugs, and many, many other drugs, especially those used in diabetics, they have risk for erectile dysfunction, in addition to the endocrine diseases, the thyroid, the hyperprolactinemia, and the hypogonadism, and the list is too long to say all of these causes. So, but to know how really we can treat erection and the causes and the risk factor of, for erectile dysfunction, we have to think about the mechanism of it. The mechanism, as we said, is very complex. It contains the higher centers up in the brain, and there is many nuclei in the vertebral, in the spinal cord, the sympathetic nerve at the L level, the parasympathetic center at the sacral level. There is the reflexogenic between the peripheral nerves, which they are either, they have either sympathetic, parasympathetic, and sensory nerves. It's also really, you have to have a very good hormonal milieu in the form of enough androgen and testosterone to have all these things functioning. Also, the vascular supply to the area, to the venous and the pudendal artery and the inferior hypogastric artery, they should be patent to have a good blood supply. And also at the cellular level, the most important thing of it is the endothelium and the cellular substrate. And there is and now this is the main really thing which we are studying these days and over the last few years about the effect of a drug which mostly work in this level of endothelial and cellular substrate in the form of phosphodiesterase 5. So really, it's a very, very, very complex mechanism. And if we look, this is a simple anatomy, and simply the venous in the flaccid state, there is the corpora here, it's flaccid, and all the sinusoid are collapsed, while during the erection, the blood supply opens under the effect of the arteries, and the sinusoids get enlarged, where they compress the tunica against the veins, and the erection happens. And this is a simple cartoon to show it how it happens, that the helicine artery in the flaccid state is usually it's not dilated, and there is an inflow which goes to the sinusoid, and this is the smooth muscles around the sinusoid where the blood goes through the venule, and this is in the fed state. While in the rigid state, the blood flow increases in the helicine artery, the sinusoidal space is enlarged, they brush the tunica against they compress the smooth muscles of the sinusoid and the wall sinus against the tunica, and at this stage they collapse the veins where the blood is trapped here, and this is what happened in the rigid state. This is a mechanical situation of the erection. But if we look at the other part of it, at the cellular level and the molecular level, it's a very complex. I will not go through all these things, but I can tell you the steps which happens. It mainly starts into endothelial cells where they secrete the nitrous oxide, and then they goes from also the cavernosal nerve, they secrete the nitrous oxide. It goes through this thing and go to the guanyl cyclase, where it converts the guanosine triphosphate to cyclic guanosine monophosphate, and also to the where the calcium here substrate. And also the other part of the story started also from the cholinergic nerves, where it secretes the prostaglandin E, and it goes also through from the endothelial cells, where a cascade of reaction goes till they reach the calcium. The main importance in the cellular liver is the calcium. When the calcium is really goes out from the cells, it leads to the smooth muscle relaxation, and at this stage, when the smooth muscle relaxed, the blood goes in, and also the erection happens. And the most two important things about this thing, while from the endothelial cells, the most important thing is the nitric oxide development. If this is deficient, and this is well known that nitric oxide is deficient in the endothelial dysfunction in diabetics, and also this enzyme, this substrate, the phosphodiesterase substrate, is inhibited by the enzyme, and this is both the cornerstones for the treatment of erectile dysfunction. And all of you heard about the baviferine injection, where it affects the other pathway of calcium and relaxation through the inhibition of phosphodiesterase 2, 3, and 4, while the new drugs, the phosphodiesterase inhibitor in the form of sildenafil and sildenafil, it also inhibit the breakdown of the phosphodiesterase part. The other thing is happened due to the cellular level, that when the contraction occurs, it's the other way around. It started by the adrenergic nerve, where the norepinephrine secreted, and it goes into the endothelial cells, which secrete the endothelins and the prostaglandin F2, and these lead to a cascade of reaction where it increases the influx of calcium here, and then goes through this kind of steps, and it leads to muscle contraction. So the mechanism of erection is very complex, affected by many substrate, and it needs a very good vascular supply, and most of these things actually affected in diabetic population. So, and this is a study to show the importance of endothelial function in a patient even without risk factors, not only diabetics. This is a study done in 32 patients with erectile dysfunction against 25 controls. They are matched for the body mass index, smoking, the blood glucose, the lipids, the cardiac function, and the blood pressure. And this patient with this risk factors for erectile dysfunction excluded, and it have been tested by acetylcholine-stimulated vasodilatation and the endothelial dependent dilatation. And if you can see easily, you can see this is the score of the erectile dysfunction by the International Index of Erectile Function, which is the standard as a questionnaire about assessment of erectile dysfunction in women. And you can see the score in the patient of erectile dysfunction is about 9, while the control who have no erectile dysfunction, the score is 22. Actually, this International Index of Erectile Function used in studies, in clinics, in all those who need to be assessed for erectile dysfunction. If the score is more than 21, we can consider it as normal. So this is the situation of the erectile dysfunction in the ED group and the control group, and you can see that how is the endothelial-dependent dilatation by reactive hyperemia response, how it's impaired in erectile dysfunction group while it's normal in the control. Also, the other thing is happening, if you look at the brachial artery dilatation, which is a measure of endothelial dysfunction, how it's really reduced in the erectile dysfunction group and the control group, it's normal. So it's very important that even patients with erectile dysfunction without any risk factors for erectile dysfunction have a bad or disturbed endothelial dysfunction. So, the importance actually of erectile dysfunction, and we should remember it even in general population, not only in diabetics, that it can uncover any other serious treatable disorders. In diabetes, about 10% of men who just presented with erectile dysfunction, they have undiscovered diabetes. Hypertension is very common. 60% of men with hypertension had erectile dysfunction. Dyslipidemia, 60% of men with erectile dysfunction have dyslipidemia. Heart diseases, this is a study done in 50 males with erectile dysfunction. It has been found that about half of men with erectile dysfunction were found to have a positive stress test, and the most serious and important thing, that about 40% of men with erectile dysfunction had actually significant coronary occlusion. So finding erectile dysfunction in diabetics or non-diabetics is a very serious problem, and you will have to look after another diseases, serious diseases like diabetes, hypertension, dyslipidemia, and coronary artery disease. And this is really a slide to show the independent risk factor for erectile dysfunction and cardiovascular disease. If you look at them, you can tell that most of them is the same: age, smoking, diabetes, hypertension, dyslipidemia, obesity, lifestyle, and depression. All of these, they are shared risk factors for erectile dysfunction and cardiovascular disease. And this is actually a slide to summarize the situation of erectile dysfunction, why it's important and how it's impaired and what its reflection on the health. If you have hypertension, dyslipidemia, and diabetes, they lead to two things: either structural changes in the vasculature will lead to atherosclerosis, and this leads to arterial stenosis and arterial insufficiency. At the same time, when there is atherosclerosis, it affects the trabeculae and the smooth muscles, atrophy and fibrosis. On the other hand, there is functional changes with hypertension and dyslipidemia with diabetes, where there is impaired endothelial-dependent relaxation. It goes to the arteries. There is impaired vasodilatation, and also the diabetes. Also, in addition to that, it's impaired the neurogenic relaxation through the diabetic neuropathy and lead to arterial insufficiency. At the same time, the functional changes affect the trabeculae of the blood vessels and lead to impaired relaxation. Both these, the trabeculae and the impaired relaxation, lead to veno-occlusive dysfunction. At the end, they lead to excessive outflow. There is venous leak. The venules and the albuginea will not really be relaxed, and it's very stiff, so that it leads to venous leak. And at the same time, there is reduced inflow of blood, and there is less turgid or very poor erection. So it's really an interplay between the cardiovascular factor, endothelial dysfunction, and erectile dysfunction is very strong. And this is actually a study to show the cumulative hazard ratio of coronary artery disease event is certified by erectile dysfunction. If you can see here, this is a patient who has been followed for up to 10 years, and to look at the cumulative probability of coronary artery disease. And you can see clearly that the patient with erectile dysfunction have a higher incidence of probability of having coronary artery disease over years, more than patient with erectile dysfunction. So checking and finding erectile dysfunction either in general population or in diabetics is very important to tell about the coronary artery disease and the probability of having coronary heart disease. And this has led to a meeting which is the Princeton Third Consistent Conference, and they recommend at the end of the conference that men should be counseled that ED is a risk marker for underlying cardiovascular disease and other health conditions that may warrant evaluation and treatment. So this is very important. Erectile dysfunction, whether in general population or in diabetics, you have to check your patient for the probability of having coronary artery disease. Now, if we come to Jordan here, this is a study done by Ajlouni. before about 10 years, and we look at the prevalence and severity of erectile dysfunction and its correlation among Jordanian men with diabetes. And by using the International Index of Erectile Function, we have the prevalence of erectile dysfunction in diabetics about 62%. About 50% of them, they have severe, and 12% moderate, and about 32% of them, they have mild erectile dysfunction. And at the same time, as usual, the independent risk factor for erectile dysfunction in diabetics is the advanced age, the glycemic control, the hypertension, the coronary artery disease, the retinopathy, and neuropathy. And actually, with all this, we have about 60% of our diabetic patients have a degree of mild hypertension. Still, it's neglected to be treatment. And in the same study, it shows that just only 7% of them were receiving treatment for erectile dysfunction. Now, sexual dysfunction is, if we assess the other way around, how sexual dysfunction impaired in a newly or recently diagnosed diabetics, we find that any patient who has been diagnosed with recent diabetics, about 20% you will have them having erectile dysfunction, and this is other erectile dysfunctions in the form of premature ejaculation or delayed ejaculation or sexual desire. You may find them in patients with diabetes. So patients with recently discovered diabetes in your clinic, you have to ask him about erectile dysfunction to check that and to help him to overcome this problem. The etiology in diabetics is nearly the same as in other populations: the advanced age, the drugs, many, I will show them later, atherosclerosis and dyslipidemia, and neuropathy in diabetics is autonomic and sensory, the control in the form of HbA1c. There is many studies actually about the duration of diabetes. It's not that really consistent in all the studies. Some studies show some relation with duration and the others did not show, but the control is very important in nutrition in general and the hormonal, the andropause. And there is many studies in diabetics where they show that patients with diabetes have really hypogonadism in the form of low androgen and what we call it in the andropause in the old age. So it's nearly the same factors as in general population in and top of diabetes and its complication. And as you see, this is the all the medullator which interfere with either erection or in the flat state and in the form of detumescence or tumescence. And you can see this is the neurotransmitters and the substrate needed for erection. And you can see most of them are affected in the negative way, where the tumescence are reduced in diabetics, while the substrates which lead to contraction and detumescence are increased in diabetics. So this is also, in addition to the vascular problem in diabetics in the form of the macrovasculature, also there is cellular level of the disturbances which lead to erectile dysfunction in diabetics. This is the drugs which used usually in diabetic population and can lead to erectile dysfunction, and you should ask your patient about them in the form of central nervous drugs, the phenothiazine, haloperidol, the antidepressant, and the other tranquilizer, the cardiovascular system, the beta blockers, the calcium channel blockers, the thiazide diuretics, digoxin, spironolactone, methyl-dopa, or reserpine, all of them lead to erectile dysfunction. And also the drugs used in the endocrine system in the form of anti-androgen, the gonadotrophin agonist, spironolactone, cimetidine, metoclopramide. Actually, for the cardiovascular system, what the commonly used antihypertensive in the diabetics is usually the ARBs, and there is no much studies about them whether they affect the erectile dysfunction or not. But there is one study which published about 20 years ago. It shows that valsartan sometimes it can help and improve the score in erectile dysfunction questionnaire. So now, is really the endothelial dysfunction, diabetic erectile dysfunction? This is a review about the hyperglycemia, the fatty acid, and this is the mechanism which occur, but I will not just take too much time to go through this, but I can tell you the study. It involves 60 patients with type 2 diabetes who have 30 with erectile dysfunction, 30 normal, no aberrant cardiovascular disease. They have spent 12-hour overnight fast, and they are giving arginine test. And if you remember the slide about the molecular level, you can find arginine is one of the more important factor in the smooth muscle relaxation, and it can measure the endothelial dysfunction. So this is the erectile dysfunction. This is the score. You can see the difference. This is really nearly severe erectile dysfunction, while these are normal. This is the number. The age the same. The body mass index. The duration of diabetes is the same, and this is the control. And you can see there is a significant difference between the control in the patient who have the erectile dysfunction and the patient who are not. And this is the parameters, the glucose, the cholesterol. You can see more or less is the same percentage. There's no much difference between them. The drugs, the other complications. And here you can see the coagulation and fibrosis in type 2 diabetes patient with and without ED. This is the patient who have erectile dysfunction, and this patient do not have erectile dysfunction. You can see that how is really significant. All this parameter of coagulation and fibrinogen significantly affecting badly the erectile dysfunction in patient with erectile dysfunction. The other thing, you can see also the autonomic and the sensory test in patient with type 2 diabetes. It shows that it's really very badly affected in patient with erectile dysfunction. And this is most of this is done in the form of deep breathing or squatting vagal cyst or fibrosis threshold in the peripheral nerve or Wermuth threshold. And most of them are significantly impaired in patient with diabetes and erectile dysfunction. So, and in general, the predictor of erectile dysfunction in diabetes, and they are all independent, it can result, HbA1c is very important, the main blood pressure, the endothelial dysfunction, the coagulation activation, and the somatosensory neuropathy, which are independent predictor of erectile dysfunction in type 2 diabetics. This is a very interesting study to show the association of depression and diabetes complication. The most people depressed with diabetes, as you can see, is the people who have sexual dysfunction. They are more depressed than the patient who have macrovascular diseases, patient who have a neuropathy, nephropathy, or retinopathy. So erectile dysfunction is one of the major causes of depression in diabetic patients, and we are really sorry to say that we rarely ask about this problem in our diabetic population. Now, when we take a look over these, what happens over the last 20 years since the discovery of the phosphodiesterase and the phosphodiesterase inhibitors, which make a revolution. That was on 1989-88 when sildenafil discovered. The situation till that time was the public and the many doctors are ignorant about available treatment for impotence, and impotence often has multiple causes, and diagnostic evaluation should include psychological, vascular, endocrinological, and medical factors. It's nothing changed till now. At that time, the only really good treatment is the intracavernosal injection with a smooth muscle relaxant. At that time, only babavarine can be used to produce good and satisfactory erection, and the surgical repair of venous leak or insertion of lympholatable prosthesis was done. That was on 1994. Let us see what happened over the years. The drugs, there is psychological counseling. The only drugs available at that time is the alpha-adenosyl blocker in the form of euhombine. There was intracavernosal therapy only just as babavarine. Now we have many other components which we can use like prostaglandin and phentolamine. Also the treatment of venous leak by surgery, which is not that good results. Revascularization as if you are doing a coronary bypass or coronary stenting, where you can improve the flow through the pudendal artery, the benign prosthesis, and the vacuum devices. Now in 2005, what only we added the oral medication, and I don't think the time will allow us to discuss any of them, but the phosphodiesterase 5 inhibitors are the mainstay of treatment now, and there's different molecules, and most of them show good response, but usually the response of these oral medication is really not good, and only just about maybe 50 or less than of this responding in diabetics, because really of the multiple pathophysiological problem encountered in diabetes. But at the end of the day, we can say if our medication fails in the treatment, we can use the intraurethral suppositories in the form of the prostaglandin or the intracavernosal injection with many different molecules, the babavarine, the prostaglandin, and the phentolamine, the vacuum devices, and also surgery. So with these things available in our hands these days till now, we can really treat most of patients, and they all all of them will be satisfied by improving their erectile function. So this is a summary about what we have said, but look at the cost. The cost is different actually. The cheapest one to use for single use is the oral medication, but as I said, it's not that really effective in diabetic, and you may need to use the intracavernosal injection in the form of multiple drugs or the vacuum devices. But you can also do the surgical procedure, which can cost between 10 and 15,000 with vascular surgery like coronary artery bypass surgery, and is very effective and very curative. If we look here at the patient choices and the preference between different treatment, this is the study done before the phosphodiester inhibitors, but in general, patients always prefer oral medications. And but the satisfaction with the response is 16%. The constrictive band, not much used because it's not natural, but there is satisfaction about 37%. Self-injection therapy, the satisfaction is very, very high, but the use of it is very little because of the cumbersome. Injecting a needle in the penis is a very bad experience, and not everybody ready to take this step. Vacuum devices also because it's cumbersome sometimes and application and needs a very little bit talented patient to use it, but the satisfaction is good. I think surgery in the form of either implantable devices or by bypass surgery is not frequently used, but it's very successful. Now with the introduction of the oral medication in the form of 5-phosphodiesterase inhibitors, I think the frequency of use is exceeding about 80-85%. As I said, the satisfaction and response is not always promising, especially in diabetic population. Now, where we are now in 2005, the erectile dysfunction was undertreated. 90% never seek care of the patient, 10% seek or receive treatment, and 5% tried or are using phosphodiesterase inhibitors only. 8 of 10 men want their doctors to ask them about ED, and this is very important. And usually the patient waits for more than 5 years to disclose the erectile dysfunction symptoms to their physician. So it's really, this problem in diabetic patients is very common, complicated, has very negative impact on the health and cardiovascular health, is really under-discussed and under-treated. And this is the situation in every one clinic. Always the patient sitting in front of you, and he said that, I hope he asked me about erectile dysfunction. At the same time, his treating doctor say that, oh, if there is a problem, I hope he will bring it up. And none of them disclose it. But many times after, at the end, after even the patient left the office, he come back again, doctor, I want to say that there is a simple thing, and he put it at the end because of shy. So I think a good assessment of diabetic patient that should be asking about erectile dysfunction in the first visit and even after in the follow-up is very important to keep the well-being of our patients. And I think I will close with this. While we strive to prolong the life of people with diabetes and improve their quality of life, we should not leave them to live in misery and to suffer in silence from erectile dysfunction. Please ask them. And may I thank you, وشكرا لكم جميعا وشكرا لأصدقائكم. وأنا في الواقع مش قادر أعبر عن سروري اللي تمكنت أتواصل منكم، ولو أنه مش بالصورة الصحيحة. بتمنى لكم التوفيق في بقية المؤتمر، وإن شاء الله نراكم الأعوام القادمة، وإحنا إن شاء الله بأحسن حال وفي أعلى مستوى، وقد وصلنا إلى ما نصل إليه في بلادنا ومع شعبنا وفي علاقاتنا إن شاء الله. وشكرا لكم جميعا.